Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health, reporting for the week of December 16th, 2024. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise of bringing the latest information on health issues relevant to us all. As you know, the People's Health Briefing is committed to cutting through the noise and misinformation and disinformation to bring the most relevant health information to you, your loved ones, and our communities. It is hard to believe, but we're about to wrap up the 5th season of the People's Health Briefing, and we would love to hear from you. Your honest feedback will help guide us in making this weekly program even more impactful and aligned with what you need most. So please take a few minutes to share your thoughts, ideas, critiques. Any feedback is welcome and will make a big difference. The link to the survey is in the post. And if you want to stay anonymous, that is completely fine. But if you want to provide your email address, you'll be entered for a chance to win one of 3 luxurious gift baskets from Clean 360, which is a workforce enterprise of Roots Community Health, where we train folks in light manufacturing as part of health, opportunity, and hope. So thank you for helping us grow together. Now let's take a look at what is going on in public health and community health for the week of December 16th, 2024. And we'll start by taking a look at viral respiratory illness activity in the United States. And for this, I will share my screen. This is a newer page on the CDC looking at respiratory virus activity levels across the country. And it's a little different than what we've seen in years past. I'll start with the level of respiratory illness activity. And this is a little bit broader than what we used to see, which was really what used to be called influenza-like illness metric, where they would look at really respiratory illnesses that cause a fever and may not include like just the regular common cold. But this is attempting to really look at all of it. So emergency department visits for a broader set of respiratory illness and trying to show what it looks like across the country. So currently it is low to moderate in most places. Kentucky appears to be high. So this can just kind of give a general sense of what's going on across the country. Although if there are localized outbreaks or things like that, it's not going to necessarily reflect well on something like this. Taking a look at wastewater across the country. This is for COVID-19. So you can see that we have a couple of states that are showing very high in Arizona and New Mexico, and also Minnesota and Massachusetts, all reporting very high. All of the striped states don't have enough information to give us a good indication. And we can also see that we now have influenza A activity. This is not differentiating between H5N1 and other flu. And as you can see, even fewer states are actually reporting on influenza A. And then looking at RSV, also several states not reporting on RSV, but we can see the darker blue states, again, are reporting as very high. So Georgia, Arkansas, Louisiana, and also Connecticut, very high, as well as Maryland on RSV. And taking a look at emergency department visits for viral respiratory illness. And this is a pretty helpful one. We know that we've seen that when the emergency department visits go up, that's a pretty good indicator that cases are going up, and is then often followed by hospitalizations and death going up. And you can actually look at these one at a time, which will probably be helpful since they're all running into each other. And we can see that little uptick where COVID is coming up. And we can also see flu is certainly heading really significantly up. There's flu by itself. And then RSV, we can see, is also heading up, not quite as significantly as flu, but we will continue to keep an eye on that. And this is also helpful. This is showing trends. So this kind of tells us what direction things are going in. So as it relates to COVID-19, we can see that a fair bit of the East Coast here actually has increasing numbers, and where much of the country is currently unchanged. And we even have, it looks like Arizona may be declining. And looking at flu, we can see that it is growing across most of the country, and that would pretty much be expected at this time of year. So nothing too shocking here, but this is kind of a helpful way to look at it. If we take a closer look at COVID, we can see that the wastewater, which remember is our earliest indicator, although it's considered low overall nationwide, we can see a couple things. First, is that the Midwest, which is in yellow, is actually in the moderate range. And second is that all of the regions except the Northeast are heading straight up. And we can see that a little more clearly if we hone in on the last 45 days. Remember, this is the gray shaded areas preliminary data, but essentially it's already showing us that SARS-CoV-2 in the wastewater is heading up in all regions except the Northeast, which is that pale blue line at the bottom. And this is showing us data through December 7th. So this is not shocking. We expected the SARS-CoV-2 increase to be happening at some point now, and it certainly has seemed to follow the high travel times that we see, which we just had on the Thanksgiving holiday. We would anticipate even more of this for the Christmas and New Year's holidays coming up, because of the increased travel, the increased mixing, and we will recall that growth is exponential. So it's getting started now, and it would be expected to rise exponentially. And that's because one person with SARS-CoV-2 can give it to many more people. So unlike the flu, you can get it more than once in a season, get it more than once in a year. So no big surprise here, but definitely a word to the wise about doing what we can to not contribute to this and to not get too lax about this, because each infection is a new opportunity, not only for a poor outcome, but in the acute phase, but also for a poor outcome longer term, like many of the post-COVID impacts we know about, including long COVID. And here we're taking a look at percentage of emergency department visits with diagnosed SARS-CoV-2. Definitely, unfortunately, this is ticking up. This is showing us through December 12th. So it does look like we may have reached our low point around mid-November, and we are now heading up from here. So the big questions now, I think, are just how quickly things will head up, how high they will get, and how many more people will be hospitalized or die. Not to mention, of course, how many will be left with some of the post-COVID impacts we know about, like new onset diabetes or the increased risk of heart attacks and strokes, as well as how many thousands upon thousands will be added to the group of folks who are suffering with long COVID, for which we still do not have any approved treatments. And so if emergency department visits did reach their low point in mid-November, then we would expect deaths to follow behind that a few weeks, meaning they would reach their low point in the first part of December before heading back up. So as expected, we can see that here in mid-November, numbers are still, they're coming down, but they're still around 500 deaths per week in the United States. So that's quite a lot of deaths. We don't have any other communicable disease killing this many people, let alone one that is spread so easily through the respiratory route. And I know none of us would want to be contributing to this number, which is why we want to keep on being vigilant and not be part of the problem. So given that we're about to head into some more holidays, we're already seeing things coming up following the Thanksgiving holiday, and we expect more peak travel days ahead, I thought it would be a good time to remind you about one of my favorite studies on SARS-CoV-2 transmission on airplanes. This study was published this past May May 21st, 2024 in the International Journal of Environmental Research and Public Health. And it's entitled "The Risk of Aircraft-Acquired SARS-CoV-2 Transmission During Commercial Flights, a Systematic Review." And I reviewed this article in some detail this past June. So the link to that briefing is in the post in case you want all the details, and the link to the article is also in the post if you want to take a look at that. But this article is a systematic review of 15 research articles describing 50 commercial flights. And this was prior to the COVID vaccine being available. And during that time, we were doing a lot more data collection. We were doing a lot of contact tracing and sequencing to a much greater degree than we are now. So we were able to really look at a lot more data. And in this particular review, they were able to remove a lot of the bias, which I went into detail about what I mean by that in the prior briefing, if you want to check that out. But essentially, they were able to really study about the transmission of SARS-CoV-2 on these flights by doing sequencing in most of the cases and just doing very thorough contact tracing so they could really see who was spreading what to who. So this is a high quality, systematic review with lots of information to inform the conclusions. And one of the main findings is that the duration of the flight predicted the incidence of cases. So if you compared a short flight, less than 3 hours without masking, to a medium flight, 3 to 6 hours without masking, the medium flight without masking had 4.7 times higher incidence of COVID cases compared to the short flight. And then if you looked at the long flights, more than 6 hours without masking was associated with 26 times increase in the incidence of COVID cases. So very, very significant. The duration of the flight definitely mattered. And these were comparing flights without required masking, short, medium, and long. And so they basically, from that, were able to calculate that for every hour longer the flight was, there was a 1.5 times increase in the incidence rate of COVID cases on the flight. The next thing that was very interesting is that even on the long flights, the ones that were greater than 6 hours, if they enforced masking, they were able to actually eliminate transmission. So they had 6 long-haul flights that they looked at where masks were enforced that had 0 transmission. So even on those long-haul flights where, like I said, if there was not enforced masking, the risk of transmission was 26 times the short flights, but they managed to eliminate transmission when masks were enforced. So the authors conclude, like I think that we all can conclude, is that aircraft-acquired transmission is not inevitable if masking is enforced. We know masking is not enforced, but that is just a statement. And lastly, it turns out that how close one sat to the index case, so the person that we later found out was positive and spread to others, was not actually the best predictor of then spreading or catching COVID. So in several instances, passengers actually got COVID from a positive person that was 5, 6, or even 7 rows away. So definitely not reassuring, and definitely goes along with the notion that you can't just wear a mask if you think someone sitting around you seems unwell or is sick, because transmission can actually happen over a much greater distance than that. And of course, people move around the plane and so forth. The article does also point out that the airline industry lost about $370 billion in the first year of the pandemic. So the reality of SARS-CoV-2 transmission on airplanes is certainly an uncomfortable one for many, but it is actually pretty simple. Airplanes are important sources of transmission. They meet all the criteria for high-risk environments because they're small, they're enclosed, they're densely populated, and aerosol particles are well mixed. And not only that, CO2 levels can get quite high on airplanes, which we have more recently learned actually in and of itself, that high CO2 stabilizes SARS-CoV-2 particles. And I linked a prior briefing where I got into detail about this. and some formative articles about this topic, about how CO2 has a stabilizing effect on SARS-CoV-2, which just means that the SARS-CoV-2 particles will stay around longer and have a greater risk of infecting others. So all of that means airplanes are one of those high-risk places where masking makes a big difference. Of course, it would make the most difference if everyone would mask, but since that's not happening, one-way masking is your best bet. So if you're going to be traveling, travel safely. Don't let COVID be your wingman. And in case there's still any confusion about the effectiveness of masks and SARS-CoV-2, I do want to share another recent article about this topic that just came out on November 27th, 2024. And I like this one because it's a very large cohort study conducted across 10 different hospitals. And what they did was look at how much hospital onset COVID, flu, and RSV happened at different time periods in the hospital, depending on whether there were masking and testing requirements or not. And hospital onset COVID, flu, or RSV means they came into the hospital without those infections, and then after being in the hospital, they unfortunately acquired those infections. So this is something we do not ever want to see, but unfortunately, we have been seeing it. And I'll just say that I've talked here before about how difficult it actually is to do masking studies. For example, you definitely can't do a double-blinded trial because everyone will know that if they had a mask on or not. And remember that blinding means that the participants, double blinding means the participants and the people doing the study don't know who got the intervention and who didn't. So that is literally impossible when the intervention is a mask on one's face. Also, there are some ethics around this because everything we know, all of the preponderance of evidence from everything we know, transmission dynamics, to physics, aerosol properties, to engineering around masks, filtration, tells us that masks are effective in preventing transmission and preventing you from acquiring these infections. So it would be unethical to compel a group to go into a risk situation without a mask, especially when it means they could then get an infection and they could then spread it to others. And I could go on and on about the difficulty of doing actual trials for masks, or really for many population level interventions. Trials are not the end all be all for all types of interventions. They're really well suited for drugs. But in these kinds of population interventions, we really need broad-based real-world analyses. And there are a few out there that I like. I've shared one before within the Boston school system, and this one I'm sharing with you today I also like. Also happens to be in Massachusetts at Massachusetts General Brigham Hospital System across 10 of their facilities. They looked at a long time period from November 2020 to March 2024, when they were able to look at the time periods when masking was required, and then when the masking requirement ended, and then they actually reinstated the masking requirement. So this gave us a unique opportunity to look at what was going on in all of those phases. So over that time period, there were over 641,000 hospital admissions. Out of that, there were over 30,000 community onset infections and over 2,000 hospital onset infections. So there were 2,075 hospital onset infections. And remember, this was looking at COVID, flu, and RSV. They actually did medical records reviews in this case to ensure accuracy, especially around hospital onset cases. So this is really important. The last thing we want is for people to come to the hospital for one thing and then actually get another thing that now they have to contend with. So this is terrible, and this is the reason why we continue to advocate for masking in healthcare. But basically what the researchers found, and they did have to do quite a lot of analysis, they did the medical records reviews, they did some modeling, which is described in the article, linked in the post if you're interested. And what they found is that when the hospital stopped universal masking and testing, it was associated with a 25% increase in hospital-onset respiratory viral infections. So this isn't particularly surprising because without masking, there's nothing that really stops hospital staff from passing infections, respiratory acquired infections around. They're catching them from each other or from patients and then spreading it to other patients. And of course, many of these patients are vulnerable. So this is devastating. This is devastating for healthcare providers to be causing illness to their patients when an intervention like masking is known to be effective. And here we have data on quite a large number of patients showing that getting rid of masking and testing was associated with a 25% increase in patients catching these viruses in the hospital. So it didn't even look at staff getting it. This was about patients getting it. And it was hard to separate out masking versus testing, which one actually was the difference. We know that it's layers, it's all about layers. But again, we're looking at a broad-based population level and just getting a sense of what happened when it was required and then what happened when it was no longer required, where we saw a 25% increase. Then later, when they restarted the masking requirement, they saw a 33% decrease in hospital onset respiratory infections. So, like I mentioned, these are difficult studies to do. Nothing's going to be perfect when you're doing this type of study. There's going to be variables. They weren't going around making sure everyone was wearing the mask perfectly, or even that everyone was following the rules. But nonetheless, when the rule was lifted, hospital onset viral infections went up by 25%. And when their masking requirement was resumed, they went down by 33%. So this is very compelling. I personally didn't need this study. I personally don't feel, or professionally don't feel, we need any more evidence to keep confirming what we already know. But I certainly do appreciate folks taking the time out to do this study because it does help address the naysayers. And at this point, I'll say that I actually don't know anyone in public health or healthcare that denies the effectiveness of masking in slowing or stopping the transmission of respiratory illness. The conversation really is more about whether they feel they can enforce masking, whether they feel what they feel people are willing to do about masking, and that's real, but let's not get that confused with effectiveness. So once again, I think unfortunately masking requirements in the general public or on airplanes or in airports are behind us in most cases. I do wish they would at least suggest them or distribute them or put up notices about how we know it can help reduce the risk of people getting sick, because I think pretending it doesn't exist is absolutely ridiculous. But I am glad to say that there are many hospitals now and healthcare settings and counties that are requiring masks. I am hopeful that now that hospitals are actually required to report respiratory illness cases to the federal government, maybe, and that's as of last month. I'm hoping that that means that now they'll be even more incentivized and motivated to do the right thing and not spread respiratory illness around their facilities. But just in case you need more evidence or anyone you know needs more evidence, I have linked this article in the post. Now, just a brief update on H5N1. We continue to hear more reports of more H5N1. We've got more H5N1 being found in raw milk in California. This is, of course, no surprise at all. The surprise is that people keep consuming raw milk. You can hear all about my thoughts on this from last week's briefing, or 2 weeks ago briefing if you missed it. But we seem to be putting effort and energy into testing and recalling raw milk, when I think our efforts would probably be best spent trying to stop H5N1 from spreading further and further. There so far haven't been any confirmed cases of humans getting H5N1 from raw milk, but unfortunately 2 cats died from consuming this last batch of raw milk that contained the H5N1. And so the more we kind of keep allowing H5N1 to just spread in new ways to new species by new methods of transmission, in this case through raw milk to cats, the more opportunities there are for mutations that could give rise to problems for us, like human-to-human spread. So this is obviously what we would very much like to avoid, but I'm not particularly seeing a lot by way of specific efforts to prevent it. Aside from stopping cattle from moving across state lines without testing, other than that, we just seem to be allowing things to progress and just watching, which is very concerning to many. More states are reporting their first cases, including Delaware recently, another one where the exposure is unknown. Louisiana also had its first case. So basically 50 states have now been affected at this point in time. Majority of cases, we know what the exposure was, but there have been a few where we don't. And so what I can say at this point is that the advice is still unchanged, although I really am going to emphasize, please don't touch dead animals. Not dead birds or don't touch any animals that are dead, because we don't know why they died. Even if it is your own animal, we don't know why they died. So best not to touch them. Get the animal authorities to do their part in this. Don't touch any wild animals, dead or alive. I just shared last week about a very sad situation of a teacher dying from rabies from touching a bat. Don't touch bats. Don't touch wild animals. Don't touch dead animals. And we have seen cases from touching diseased or dead birds that then go to humans. So don't do it. And I will point out that there is a new technical summary from CDC from December 10th. This was about the pediatric case here in Alameda County that I reported on last month. This child had no known exposure to poultry or cattle or anything. We don't know really how this child actually got H5N1 at all. But without getting into too much of the details, you can check those out yourself if you like in the technical update, which is linked in the post. But the bottom line is that we couldn't get a completely definitive answer on the viral genotype, meaning the whole entire genetic makeup of this particular H5N1 that got this child sick. But it does look like what the child got is very similar to what we're seeing in the other human infections, like the ones we're seeing in dairy workers in California. So still don't know how the child got it. No animal exposure has been identified, but this particular case does not appear to have any concerning mutations at this point in time. I'm still concerned that we don't know where the child contracted it. That just remains a big question mark. We know that there was also a teenager who was in critical condition for over a month in Canada. I reviewed that one previously. And in that particular case, the sequencing did reveal some concerning mutations. We have no update on the condition of that teenager. But there have also been no other cases that we know of that show that particular set of mutations. So we're basically just waiting to see what happens next. But at least so far, that update is reassuring. And we don't know of any human-to-human transmission so far, so we are just going to stay tuned. And now I have several brief reminders. First, a reminder that the benefit that covers telehealth is set to expire at the end of this month. So if you have not already, I would encourage you to drop a note to your representatives asking them to preserve this life-saving benefit. I talked about this in some detail in last week's briefing, but I did also link in this post the link to send a letter. It's actually really simple, only takes a few minutes. So please join in that advocacy, because it would really make no sense to end telehealth access. Next reminder, if you haven't gotten your free COVID test, now is a great time to order them from the government. The link to do that is also in the post. Next is a reminder that if you haven't got your vaccines for respiratory illness, now's a great time to do that. If you haven't gotten the 24-25 COVID vaccine, now's actually a very good time to do that. You'll be more protected as those cases start to go up. Same thing with flu. Also, if you're within these eligible groups, ask your provider about pneumococcal vaccine and RSV vaccine. And another reminder, if you're getting together with folks over the holidays, now's a great time for everyone to agree to be a little extra careful in the days leading up to your gathering. If everyone was to mask for 10 days before the gathering, you could really reduce the amount of transmission that happens and keep your event from becoming a super spreader event. Let's break those chains of transmission. just one person with SARS-CoV-2 can really infect a number of other people. So every infection that you prevent is doing a lot. It is preventing a whole host of others so that it does not have to happen to them as well. So best thing we can do is mask up. Let's also strategically use those tests, especially right before a gathering, as well as after potential exposures. Let's stop those trains of transmission, and hopefully we can reduce the number of people going to the emergency department, hospital, dying, or having post-COVID consequences. And if you do end up catching something, remember that if you're someone who's at risk of a poor outcome from COVID or flu, then you are a great candidate for getting early antiviral treatment for COVID. So if you're older or if you have any underlying conditions, then we want you to be aware of that now. Have a treatment plan for COVID. For most people, that's going to be Paxlovid. So just make sure you have a treatment plan. This also means you got to get tested right away so that you'll get treated in time. The sooner, the better with these viruses, because they're going to halt replication and keep you from moving on into that more severe phase, the inflammatory phase. And that is what we're trying to prevent. And generally, to have a treatment plan, to get a prescription, that is going to require that you have a primary care provider. If you don't have one, please get one. Know how to reach them before you need them. Make sure you have a relationship with them. Make sure you have a plan. And another reminder to please take a moment to complete our survey linked in the post. And we hope to make 2025 another great year with the People's Health Briefing. This concludes the 2024 season of the People's Health Briefing. Thank you so much for joining us. We'll see you again on Tuesday, January 7th at 10 a.m.